welcome to another episode of Gender Queries, a podcast about trans and gender diverse healthcare in Atlantic Canada. I'm AJ, and I use he, they pronouns.
I'm Jess, I use she and they pronouns.
I'm Sam, and I use they, them pronouns.
Today we're going to take some time to explore the intersection of disability and gender identity. We'll look at shared experiences, unique challenges, access barriers, unmet health needs, neurodiversity, sex and sexuality, and we'll hear about some practical ways to better support disabled, trans, and gender diverse patients. The takeaway from today's episode is really that even if someone is accessing healthcare that's unrelated to their disability and unrelated to their gender identity, these identities and this intersection will fundamentally influence how someone experiences healthcare.
Not everybody understands what intersectionality is.
Intersectionality is the idea that identities affect the way that you experience the world. Mm-hmm. Identities exist on their own, but they also interact.
Mm-hmm. Your collection of overlapping identities and experiences make your experience unique, and that also sometimes having those overlapping identities can have a bit of a, I don't know if synergistic effect is the right word, but they can result in more marginalization than just the sum of them together.
Mm-hmm. And I think a lot of it is how you experience either privilege or discrimination differently based on the particular identities you hold.
What kind of shared experiences do you think that the disabled community and the trans and gender diverse community might have?
Something I often think of is how the lack of provider education or provider comfort in working with someone from the disabled community or someone from the trans community leads to situations where providers will avoid particular aspects of care altogether.
Yeah, I was also going to say potentially the experience of when you're seeking healthcare for something unrelated, there being a certain amount of bias or assumption that your issue is related to one of those two identities. So, for example, assuming that a given symptom that you show up to emerge with is just part of your disability or that it's normal for you and not an acute issue that's unrelated.
Or it's because you're taking hormones, it has to be that has to be why you're experiencing such and such.
There are a lot of overlapping forms of discrimination that people of either of these identities might experience.
For example, according to Joukhadar and colleagues in 2017, both trans and gender diverse and disabled people are more likely to have mental health problems, more likely to experience sexual assault, but less likely to come to rape crisis centers, and more likely to experience intimate partner violence.
What do you think happens when somebody holds both of these identities?
Are they more likely to experience mental health issues, partner violence, etc.?
Yeah, these factors are compounding on top of this. Somebody who is disabled and gender diverse is going to experience higher levels of anti-trans discrimination, even in places where they're seeking help, like a mental health center or a domestic violence shelter. There was a paper by O'Shea and colleagues out of Australia in 2020 that described a recurring theme of disabled, trans, and gender diverse people in healthcare settings struggling to manage multiple identities. So they described feeling like they could either approach their provider as a disabled person or as a gender diverse person, but not as both.
My name is RJ. My pronouns are he, him. I am a third-year medical student. I'm also a wheelchair user and identify as a trans man. I transitioned about 5 or 6 years ago. In health appointments, I have to go in either talking about a trans thing or talking about a disability thing, and I don't think I've had any provider ever ask me or discuss how they both are intersecting, because I think I've had providers who have been uncomfortable speaking about either. So we're not talking about both at once.
Yeah.
My name is Rachele Manett, and I use they, them, and she, her pronouns. And I am predominantly a sex educator. That's like my main sort of title, I would say. When it comes to the over-medicalization on both fronts, a lot of disabled people who have sort of higher medical or support needs have to choose between getting that care or getting gender-affirming care. And that can be for a variety of reasons, whether it's personal care workers not being up to date with gender exploration and gender expansiveness and just not supporting those experiences. And so people, if you're not the person that dresses you in the morning, how do you get to choose what kind of clothes you put on, and who is a safe person to say, I actually want to try wearing a dress today, or I want to try shaving in this way, kind of thing.
If someone is coming to access care that is not related to their gender affirming care and it's not related to their disability care, why is it relevant?
I think it becomes relevant because it's ultimately how I interact with the world, and my healthcare appointments don't just shut the world out from that. As much as I think there's sometimes this algorithm of going through an appointment and trying to be efficient that wants you to, I'm showing up with all these experiences. For one, my identity is part of like my name and my pronouns, so it's great if a provider can be aware of that and then use the proper ones. The disability side, I think because my disability is so visible that they're already going to be aware when I roll in. But there's often questions about, like, if you have to do an exam, if they don't have a high adjustable exam table, there's like, oh, how are we going to do this? I think in that appointment, there's just so many times where both those identities come up that it makes sense to just have it as part of your continuum of care.
Mm-hmm.
And if a provider is recommending treatment options or different clinicians that you should see, that ultimately comes down to the choice of the patient. And I am much more willing to trust what my doctor is saying if I can tell that they've acknowledged what my world experience is and how this is going to affect me. Anything that comes out of an appointment that involves a treatment plan, that's work for the patient. And that's adding work to already someone who might be experiencing discrimination in different ways.
Well, and having to navigate systems that aren't built for you is exhausting. If those identities you hold lead to you being exhausted just trying to navigate the system, it's going to be exponentially harder for you to also help support your health.
So these identities definitely influence how someone experiences healthcare. And we know that people that hold these identities are more likely to have had negative healthcare experiences, which can reduce trust and lead to avoidance and contribute to worse health outcomes. Queer individuals are more likely to acquire disabilities throughout their lifetime. And this is probably due to the healthcare disparities that people face, and part of that might come down to avoidance of care. There was an observational and descriptive cross-sectional study in 2022 out of the States that used internet survey data. And the researchers showed that after adjusting for sociodemographic characteristics, disabled, trans, and gender diverse participants reported higher rates of unmet health needs than disabled cis participants. So we know that the intersection of these populations results in unique challenges in a healthcare setting.
When I was being fitted for my manual wheelchair, I still bind, right? I bind every day. And pushing a chair with a binder on, it's not comfortable. You can't not move yourself around. But that discussion just never came up of, like, is there a way that this chair fitting would fit better knowing that I have this restricted movement on my chest? And that conversation still hasn't come up. But I do think that it would be worthwhile. Some days, I'm like, I think I can get away with using my power chair today and not my manual, because it's one of those, like, weird bind days where, like, I don't want to be moving around a lot. Things aren't sitting the right way or so for some reason, and so I'll use my power chair. But I now have that option that I didn't before, and I think before I just went out less, or I was less willing to do physio exercises. And these are just things that didn't come up with my providers at any point, because that was an appointment about my wheelchair, not about my trans care. But they do both exist.
I remember someone had come into Venus Envy and they were a wheelchair user and they were looking to try on some binders and they couldn't get the binder on themselves. And so when they came in, they didn't want to bring a support worker, and they sit all the time. Like, that is their experience. They're always seated, and their spinal configuration and their rib configuration was really specific. And we were trying on all these different kinds of binders, and the issue became like none of these are something I can sit in all day. All of these are compressing all the wrong parts that can't be compressed. What do I do? And it was kind of like, I get that. I also have that issue. I can't really bind anymore because of where my ribs and my spine are aligned, or not aligned for that matter. And so, yeah, it becomes like, what kind of gender affirming garments are even accessible to you if you can't go the surgical route, if you're just going the sort of day to day, what I'm going to try to make myself appear the way I want to.
We know that barriers exist for disabled people and trans and gender diverse people separately. And when someone is multiply marginalized, the barriers are amplified and new ones appear. We touched on higher levels of discrimination earlier. Some other barriers might be insurance that covers medication or equipment costs, accessible transportation, the ability to self-advocate, or living in a rural area. What do you guys know about TransPulse Canada?
I know they did the big national survey, but a lot of the work that I look at, especially when it comes to like barriers to care and some of the more social determinants of health, comes from some of the TransPulse studies.
Yeah, it's a community-based research team. They published data suggesting that disabled, trans, and gender diverse participants self-reported lower levels of health, healthcare access, and well-being compared to trans and gender diverse participants who were not identifying as disabled. Additionally, in general, trans and gender diverse folks may feel pressured to perform gender roles in order to access gender-affirming care. For disabled, trans, and gender diverse folks, they are more than twice as likely to be avoiding a diagnosis of a health issue in order to access gender-affirming care.
That's interesting. I think it's a common theme that kind of comes up, having to perform a particular way in order to access gender-affirming care. And because there's been such heavy gatekeeping for so long.
We now have informed consent models, but we didn't used to. You used to have to get mental health assessments, etc. So there's already that fear that, for example, if you have another mental health condition, that your gender identity will be questioned, and so you won't be able to access that gender-affirming care, so you don't want that mental health diagnosis because you don't want to impact your ability to get gender-affirming care, because that's a fear that people have.
According to the TransPulse research, 7% of disabled, trans, and gender diverse participants who responded to the survey said that they had been denied gender-affirming care due to their disability. And that's a lot.
Mm-hmm.
That's a lot. I wonder why.
I could imagine a lot of it might come from that biased assumption of inability to make your own decisions and to make an informed decision for yourself.
One of the biggest barriers that I've seen around trans care and having a disability, at least on a physical disability side, but I can imagine that this does come up on more of the invisible disabilities too, is that access to medical transition relies on a physician believing you have capacity. And with disability, you're often assumed to not have capacity.
I could also see how you might be concerned that you'll be prescribed medication that means that you can't take gender-affirming hormones, or that you'll become a complicated patient, and so accessing gender-affirming surgery will be more complicated. Like, there's definitely all these worries that would come with additional diagnoses and additional health concerns.
People wanting to access more like surgical or hormonal gender affirming care, there's a lot of medical reasons they might not be able to based on, other medical things that they have going on.
My name is Gabriel Dit L'individu, and my pronouns are he, they, or il, elle in French. I will go by he or person or man in American Sign Language. I am a disability and access educator, as well as an access barrier consultant. For me, my biggest experience with being outright denied care was for my top surgery. I was using a power wheelchair at that point. I was very close to paraplegic. And when I went to check in with a surgeon in 2019, I believe, and I was like, I want to have top surgery. Didn't include that I was using a wheelchair. Didn't think it mattered. You know why? Because you come out of that surgery using a wheelchair. They send us your pictures, which is also the weird part. Suddenly you send topless pictures to an email that you don't know. The weirdest titty pics you've ever sent to anyone. And then seeing that I was using a wheelchair, the email I get back is, I'm so sorry, but we actually don't do top surgeries on wheelchairs. I responded to that email with, my wheelchair doesn't have tits. I do.
I am in the process of getting top surgery, I'm on the wait list, but one thing that has come up in discussions around disability and accessing top surgery specifically has been that some doctors don't want to do the surgery on someone with a disability because of quote-unquote frailness, and saying, well, you're too disabled to have this surgery. I just don't think it'd have a good outcome. But now that I know a little bit more from the medical side of what we actually identify as frail, that argument makes even less sense to me sometimes. And that's a concern I have going into top surgery discussions with the doctors, that I might get off this wait list and they might say, oh, yeah, I don't feel comfortable doing this because you're in a wheelchair. Recovery from a surgery is going to be different and most likely longer for me having a physical disability. And I will need more support And I think that what I need when I go into that appointment with the surgeon is to have a discussion on what does that support look like.
I'm Dr. Joukhadar. My pronouns are he, him, and I'm a plastic surgeon here in Halifax. I'm assistant professor at Dalhousie, and my focus is on gender-affirming top surgery. And I also have a special interest in medical education as well. During my fellowship, I had plenty of differently abled patients, like wheelchair users and using other ambulatory aids, and it was never an issue. There's stages of what you want to do. So in preoperative planning, you want to possibly coordinate with OTPT, see if there's any adjuncts that can be used to help assist them in the post-operative recovery, especially with the restrictions. I've had a couple of patients ask, okay, how am I going to transfer after? Because you're not supposed to use your pecs. And really, if OTPT can give us some suggestions, great. But otherwise, I usually just tell them, like, you have to transfer. You're going to have to use your pecs a little bit. If something happens, you just know that you're going to have a little bit of an increased risk, possibly of a hematoma or a stitch pulling, and we'll deal with it afterwards. It's not the end of the world, but you have to transfer. Just try to not use your pecs as much as you can. But other things you can do with preoperative planning, like ensuring you have an operating table and transfer equipment that are available that will work with the patient. And then also I just indicate on my form for my administrative assistant, just whatever equipment the patient utilizes so they can tell the OR so they know ahead of time. And then for anesthesia and positioning, you want them to know as well, and you want to avoid any pressure injuries in certain patients as well and accommodating limited mobility. Then for the post-op and discharge planning, that's where OT and PT would really get involved. And then if they need assists, like with wound care, you can get VON involved, for example, so home nursing or any other equipment that's needed. Even in the post-operative care, I haven't had anyone with any complications like I was mentioning, but it could happen. I mean, it happens to plenty of patients. Statistically, it's just going to happen, so it could, but I really haven't encountered any issues, honestly. I also haven't encountered any barriers, I should say, from the booking perspective once I've seen those patients. But that's not to say that's universal for everyone, but in my hands, it hasn't, at least. And then, of course, like with any patient, just avoid discrimination. Ensure that you are not denying care because of someone's disability, which I can't imagine should ever happen. And just assess and mitigate the individual risks and provide accommodations based upon that. But yeah, it's sad that people are encountering those barriers. I'm not surprised, of course. I know there's the data for that, but I think the more education we can get out there on that it shouldn't really make that much of a difference in their care, the more access they'll have, I hope. I understand the anxiety or the worry, or you don't want to cause harm, but if a patient's informed and they're making an informed decision and you can just describe to them those risks and that they maybe be slightly increased, they can make an informed decision on their own terms in that matter. And so I think that's always the safest way to go. So just let them know those possibilities, but they're probably already aware of that, honestly, because everyone's so well informed before they come and see me so often. They've done tons of research. But if they're not, you provide that information for them.
Do you know how your patients have, how it's been for them to access the supports like VON and OTPT, that kind of stuff?
It's going to be different, I guess, for different centers. For us, where I'm located with a Nova Scotia Health facility, I'm in Halifax Infirmary often, or Scotia Surgery, or Bayers Lake. There's OT that comes to Bayers Lake. There's OT at the Halifax Infirmary. And I've developed a relationship with a lot of them through residency and that. So anytime I've needed OT, they've been so lovely and so available. With that being said, I haven't utilized their supports for top surgery purposes yet, but I know I've used them for a variety of different resources. So I can't imagine them at least trying to help in that way. With that being said, not every hospital has an occupational therapy or physiotherapy department that's as easily accessible. So that's not going to be a universal truth for everyone. But yeah, for me personally, I haven't encountered any barriers or issues there, but that's not to say someone wouldn't. I'm sure plenty have and will. But I think one of the things you can do is if you are at a smaller center, for example, or you just don't know what you have available, you can call any of us, any colleague, you can call the occupational therapy department in Halifax just to get further information, or in the periphery. I've done that plenty of times just to ask over the phone, like, do you guys have these things available? As for VON, the only times I've encountered barriers is there's certain periods of time where they will send out bulletins saying like, we are overwhelmed right now, like we don't have enough resources, and then we know that, but generally they've been very good and they get back to you quite quickly.
This approach can also be applied to other gender-affirming surgeries, and you don't need to have all the answers, and you won't, because every disabled person's needs are different.
I think that the best healthcare that happens is once the team's set up, right? The patient is part of that team. And I think one of the worst things that can happen is a provider makes an assumption oh, the patient doesn't need to know this, but they do to plan properly for aftercare, for preparing for the surgery. And the patient doesn't have that knowledge. The provider does. So sometimes it is saying, I don't know if this makes a difference, but these are some things that people experience after the surgery. Do you need any help navigating some of those supports?
It took me 2 more years then to find a surgeon in Peterborough, Ontario. I could not find a surgeon in Toronto. It was my surgeon's 5th time doing a top surgery. And I trusted him because he looked at my body. He said, okay, you're a wheelchair user. I will leave fat in certain places because you're more likely to be built up here and it will show pecs better. That is the day I felt like a care provider saw me as both trans and as disabled. Looking at your patient as a whole, that is affirming care.
Having disability typically comes with having a few more medications on board. I personally haven't had any discussions about medication interactions with testosterone. I think that trans care is often seen as secondary to other healthcare, even when we know that it's life-saving care. And as a patient, I know where I would prioritize things personally in trans care. And this is an assumption, but I believe that it would fall higher on my priority list than on my doctor's priority lists. Mm-hmm. Because if I'm on a medication that helps with one of the symptoms I have from my physical disability, and if we knew that that interacted with testosterone, well, I might be more willing to just live with that symptom mm-hmm. than give up my testosterone. But I don't know if that would be the recommended thing, because I think living with a disability is seen as really hard. And it's not easy. I'm not saying it's not hard, but I think sometimes it's perceived as being more complicated than it ends up being when you get adapted and adjusted to it. We often say, like, well, think about what you would do in that position, but we have this, like, first day effect. So that's what I see it as, where you can ask someone, oh, if you had to be in a chair, how would you manage that? But you're only going to think about your first day in that chair, and not now going on 4 years, adapting and living with it. It's so much different than that first day, but that's hard for someone to understand without living it. Mm-hmm.
There's not a lot of research on drug-drug interactions with hormone therapy, but I did find one study by Kim and colleagues that used existing literature on the pharmacology of psychiatric medications and HRT in general. They looked at gonadotropin-releasing hormone agonists, which are used as puberty blockers and sometimes as an antiandrogen. They talk about QT prolongation, seizures, and osteoporosis. They also took a look at estrogens, looking at things like VTE, weight gain, dyslipidemia, other metabolic changes. We know that estrogens and testosterone are both metabolized in the liver, primarily by CYP enzymes. So when you're taking medications that inhibit or induce these enzymes, that can increase or decrease the level of the hormone the patient is taking. In terms of psychiatric medications and testosterone, originally testosterone was thought to destabilize psychiatric disorders, but the research has proven that to be untrue. They talk about testosterone and psychiatric medications and the risk of hepatotoxicity. We know that testosterone can result in a transient mild elevation of liver enzymes, and then VTE comes up again. It's not a contraindication to take or prescribe hormone therapy and antipsychotics concurrently, but there may be some additional monitoring that could be beneficial.
Let's talk a little bit about autism. Trans and gender diverse individuals are significantly more likely to be neurodivergent than cisgender individuals. There was a 2020 study by Warrior and colleagues out of the UK that showed that trans and gender diverse people were 3 to 6 times more likely to be autistic. The authors discussed several hypotheses, including that autistic people may be less likely to conform to societal norms, which could contribute to a greater number of autistic people identifying outside the gender binary. And there's also been some research looking at the role of sex steroid hormones in neurodevelopmental conditions and gender role behavior.
And this idea of not conforming to societal norms could also help to explain why we see such high rates of queerness and transness in the disabled community more broadly.
Living with a disability, you get quite used to being a little different from everyone else. And so I think people who are queer with a disability maybe are more comfortable coming out at that point
Mm-hmm.
because they're already used to this discomfort.
Mm-hmm.
The things that we all have in common is recognizing that we don't necessarily fit into this world in the way that is sort of prescribed to us. And so when we're already not fitting into that box, why not explore some of the other boxes? And then it turns out those actually worked really well for a lot of people.
What do you know about recognizing autistic characteristics in children?
I know that there used to be a very stark gender divide, and that for a time they actually thought that it was truly something you almost entirely saw in young boys. That's no longer the case. We know that it presents in girls as well, but that it tends to present differently.
Yeah, exactly.
Are we saying young boys meaning those assigned male at birth, or?
I don't actually know if those boys are cis boys,
Right.
but it's whatever the scientists perceive
Right.
to be boys.
Right.
Yeah, so even though there is that shift to recognize characteristics in young girls, it's still unclear if there is a particular set of characteristics that would apply to trans or gender diverse people.
Mm-hmm.
And when it comes to access, what do you think that looks like for these youth?
And depending on the support needs of the autistic person, you end up with a situation where they may experience additional discrimination trying to access whatever supports they need or trying to access whatever is typically available to autistic youth, for example. So they might face additional discrimination there.
I wonder what level of disbelief exists within providers in not respecting that that person knows themselves.
Yeah, like if there's infantilization of autistic folks when it comes to them wanting to access gender affirming care, are they believed, are they considered to be in charge of their own care? Are they in charge of their own care? Because you do have situations where someone might have higher support needs and be engaged more in shared decision making, who still wants to access gender affirming care. And then it's not just their decision, but they still do need that decision making support. So what do you do? But the same would apply to any health decision. I can see how that would get tricky.
In a paper written by Strang and colleagues in 2018, the authors described that trans and gender diverse youth experienced challenges verbalizing and self-advocating for their gender needs due to their autism-related communication differences. They're often misunderstood, or their gender needs are met with reluctance, and they also may struggle to navigate the steps to accessing gender-affirming care.
Those are complicated steps, man.
My name is Dr. Sarah Fraser, and I am a family physician, and I specialize in gender-affirming care and currently practice gender-affirming care full-time at my clinic, Coastal Gender Affirming Care.
Does the informed consent process look different for patients who are neurodivergent?
I think sometimes the assessment process might take a little bit longer. It might take longer for the patient to also feel comfortable, and it might take different sorts of questions that you might want to ask. So I have one patient who has a more severe form of autism, but really it took like 5 or 6 visits for that patient to then start communicating more openly. And in the first couple of visits, it was one-word answers. And one of the LPNs who I work with and myself were ourselves questioning, does this person have the ability to consent? Because we would ask questions in many different ways, and it was just yes, no, and there was no elaboration. But I think once you build that trusting relationship, then answers started to come out more comprehensively. So I think not in the aim of delaying care to an inappropriate extent, but sometimes it does take, instead of starting hormones on the 3rd visit, which might be an average number when I might start people on hormones after their initial assessment and see them again, get blood work done. And, we're a month or 2 into the process and getting people started on hormones. But you might need more sessions to really accurately assess a person's ability to consent. And then just framing questions in different ways. If there's a supportive person in that person's life who can also communicate with that person, that helps to assist them. Now, that person might not always be supportive, and it might be someone who is the opposite. So you kind of have to be careful about that as well. But those would be a few strategies.
So we've talked about healthcare access. What about in the community? Why do you think that community is a protective factor?
Not feeling isolated is very important for mental health.
I think it also gives a sense of like a shared experience and shared understanding that can kind of come from community. Having that support to be there for you to say, yeah, what you're feeling is valid and I've experienced such and such as well. And, this is maybe how I dealt with it, or, these are some resources that helped me.
There was a report made in 2018 by Leonard and Mann that looked at existing literature to see the effects of systemic discrimination on the health and well-being of queer and trans people with disabilities in Australia. There was a theme of dual exclusion, where disabled, trans, and gender diverse people felt excluded from both the queer community and the disabled community.
The person who is most likely to be excluded and feel like they're living in these little pockets of places that they are accepted is going to be based on who is most likely to be marginalized. A lot of times that is going to be folks who are requiring care with them 24/7, who are going to be using power wheelchairs and are not going to be able to go into an event if it has stairs.
Spaces not being accessible is really where I get excluded from queer spaces. Part of that is that they're already so underfunded. They're just trying to find a space. You're not going to find the space that doesn't have stairs to it. You're not going to find the ideal location. And you're also not going to have access to funds to modify that space. And so I think that's where I see the exclusion happen. It also comes from a lack of education that we have given to people who organize events to know about the accessibility. I can't remember the last time I saw a sign language interpreter at a queer event. You can say, we just don't know anyone who's queer and deaf. Well, they're not coming to the event because you didn't provide the right access.
Trans people have talked about feeling excluded from the broader queer community, and that's sometimes on the end of the trans person. If they are trans and straight, then they don't feel like they fit in that community. And then sometimes it's also from discrimination from people within the community.
I saw that as my transition went on. When you start to pass, I think it becomes a question of, do I fit into queer spaces? Because they might not know, right? It's probably the one space where you're like, somehow I want to tell you I'm trans.
Yeah.
To tell you this is a space I think I do belong in. Aside from gender, also my sexuality was already within the queer community, so I didn't see that as much.
I've never necessarily had that sense of comfort or belonging, in the sense that being asexual, I felt like I had to put on like a presentation of myself to some degree in certain groups, settings.
That's a really good point, and we're going to talk more about the intersection between disability and sex and sexuality. First things first, let's hear a little bit more about Rachele Manett's work as a sex educator.
I've been involved in research and mostly education around sex-related topics, and that could be sexuality, gender. A lot of my focus tends to lean towards disabled sexuality and sex and disability sort of more broadly, and how those two things intersect, how those experiences intersect with queerness and transness and gender. I am a certified recreation therapist. I have quite a lot of background in disability studies more broadly, and then also in adaptation and working with people to do what they want to do, leisure, recreation. That can really mean anything. And in my mind, it means sex. So that's a lot of the focus that I've had, and all the little pieces that meld together to make that happen. People get sent to us to talk about medical concerns because we're the ones who have that knowledge, apparently. And that's as intense as doctors having patients who come in saying, like, I have pelvic pain, I have pain with penetration, whatever. And they literally say, go to Venus Envy. They'll help you. And I'm like, we are not doctors, but okay. So I'm lucky that I have such an extensive background in healthcare.
What's the biggest stumbling block when you're educating providers?
Yeah, I think the most common thing that I run into and the most common question I get asked is, how do I bring this stuff up? People are really afraid to say the wrong thing or afraid to make someone uncomfortable. And so they're like, I shouldn't even talk about sex or sexuality, especially in, I think, what a lot of people consider more like vulnerable populations, whether it's disability or whether it's someone that is queer and trans. Yeah, I think a lot of practitioners are just like afraid to do harm, but by ignoring the situation, they're actually causing more harm. I think also they're not getting a lot of education on what to do once they bring it up. It's not just about like starting the conversation, then how do you have the conversation once you have actually started it, once you take the lid off that treasure chest of knowledge, what's inside. And I think that's also where people get really choked up or stuck, especially when it comes to sex and sort of like the playfulness of sexuality in medical systems. That isn't really taught. And I think it can't be taught in theory. Like, it really is so individual and beautiful because of that. But also, I think people need to understand just that in and of itself. If we just, I don't know, if healthcare practitioners can just get on board with the fact that they actually don't know everything, then it probably would help them have these like larger conversations. And sort of similarly, when it comes to disability and sexuality, not only are people afraid to like do harm or make a mistake, but they really just don't understand the expansiveness of sexuality in general, and then how that might apply to someone with a disability. And especially when we're looking at disabled sex or disabled sexuality, the way that I like to look at it is that it is expansive, kind of how I would also relate to queer sex, that there is no one single definition of what that means. And so trying to be like, how does this person fit into this box isn't going to work for a lot of people. And of course, healthcare practitioners are going to be confused about that. So
another element beyond discomfort or lack of knowledge is pathologizing. If a trans or gender diverse person's sexuality or sexual behavior doesn't align with normative expectations, it can be seen as a symptom or a pathology. There's also a common experience that trans and gender diverse people might have where a provider assumes their sexual orientation, and this can result in inadequate counseling. On the other hand, it's not uncommon for providers to neglect addressing sexual health at all. Often, the word asexual is ascribed to disabled people, not as a label to describe their sexual orientation, but as an assumption about their behavior. This is so ingrained in people's minds that providers will assume that partners of disabled patients are personal support workers.
Yeah, no, I've not had any provider talk about sex since having disability, and I also had very few conversations when it came to the trans side as well, though I got nothing after the disability part. I think they don't really want to discuss it.
In cases of long-term catheter use, using an indwelling suprapubic catheter can be more comfortable for patients. It can have a lower long-term risk of infection, and it often poses less of a limitation on sexual function than a urethral catheter. Gabriel was in a situation where he wanted to switch from a urethral catheter to a suprapubic catheter.
I had been having my reinsertions done by nurses at home, and then I needed to do one at the hospital. I was going for, all right, we can't no longer have an indwelling catheter. And I was argued with by the doctor. The reasoning of not having an indwelling catheter was both for pain, for comfort, and for my sex life. And I told that to the doctor. My mother, unfortunately, was in the room, got caught in the medical curtain like a raccoon, and just spun around for a little while. And the doctor's standing there and he's like, oh, I didn't think you had a sex life because you used a wheelchair.
We see among the queer community in general kind of the flip side, and it can come from the liberation movement, but we see like a hyper-sexualized community in some respects within the queer community, and so I think that itself can also negate the asexual identity, and people who do hold that identity may feel a need to either not express it or feel abnormal in some way.
If you have these biases in your mind where you see queer people as hypersexual and then you see disabled people as asexual, what happens when you have a queer disabled patient? Which one of those biases wins?
When these stereotypes are brought up in the work that I do, it's generally related to the perceived asexuality of sort of the entirety of the disabled population, which is bananas. And I always like to try to remind people, and this is the framing and the language that I try to use, is that the issue is that there's a desexualizing of people with disabilities. Because asexuality is a valid identity and is part of that larger queer and trans community. Because of the term that we're using, we often subscribe this behavior to this whole group of people, both asexual people who aren't disabled, and then also all disabled people. in sort of the lens of intersectionality, there's an entire group of people now, actual disabled asexual people, who are like not really welcomed anywhere. A lot of asexual communities, for a long time, they've been associated with disability because there's something wrong with their sex drive, or there's something wrong with them if they don't want to be having sex all the time. And so they really push away people who are disabled from their community in an effort to not be associated with disability. And then on the other hand, the sexual revolution of disabled people has been super important in the history of disabled rights for good reason. But through that, there's sort of this forgotten community of people who actually don't want to be sexual or aren't interested in sex. And we lose them in that. And, the sexual revolution, in my mind, should mean everyone comes to sexuality in a different way. And we should all be willing to accept that, as long as it's not hurting someone else, obviously. And also, the reason that a lot of disabled people are desexualized is because they are considered childlike.
These biases affect care. A lack of awareness of the diverse ways in which people can experience and express their sexuality, or a failure to recognize that disabled, trans, and gender diverse people can have sex, or the assumption that disability negates gender identity or sexual orientation, leads to inadequate or absent sexual health care for these patients. A simple step that makes a big difference is, when relevant, taking a good, consistent sexual history. We've talked about how identities shape experiences, challenges that people face, and biases that are pervasive in our culture. What about strategies? What can we do to better support disabled, trans, and gender diverse patients? The first thing to remember is that neither of these identities are a monolith. So how can we improve access when there are so many conflicting access needs?
I think this is very much like that sort of person-centered care, meeting people where they're at and finding out the things that they need and also what they already have access to. And, this isn't every person, but I think a lot of people have multiple resources that they have figured out for themselves, or that has been figured out with the help of the support person, to navigate some of their access needs that aren't regularly navigated outside of the house, perhaps. And so, when it comes to the example of bright lights overstimulate someone, but is necessary for someone else to see, figuring out, assuming it's two people, what resources do they have separately? What resources do they use in other spaces where maybe the lighting can't be adjusted? And which one of those resources is going to be the most easy to utilize and the most appropriate to utilize? And so if one person is like, I can't see in this lighting, but there's something I need to read, there's nothing I need to take in visually, I have other ways around this, perhaps a sighted guide, or if Braille is available and they know how to read it, then that person can utilize those resources, versus if someone who gets overstimulated by bright lights has resources like specific kinds of glasses or things to lessen that stimulation, then they already have those resources and then we can utilize them. I think saying that we personally have to meet each person's access needs isn't fair. I also feel like we don't give people enough credit to handle their own access needs when necessary. We don't have to baby people. And that doesn't give people that opportunity for self-determination or for autonomy and bodily autonomy, giving people the options and just giving people all the information. And this is why I'm a very big proponent of really detailed access notes. I let everybody know what they can expect when I run an event. All the things from getting in, from the type of transit that's available to them, where it drops off, where to park, what kind of door they're going to reach, what the bathrooms are like, and what the lighting might be like. And I always say, come and talk to us if you think that you have an access need that we can meet that isn't currently being met, but also here's all the information that you need to make your own choices about your own access needs. If I read a bunch of access notes that say there are no chairs here, then I'm going to know to bring my own. But if it doesn't say anything, I might assume there's a chair and not bring my own and then be stuck or have to sit on the ground, which is fine for a while and then very quickly becomes a nightmare. So, giving people all the information that they need to make choices about themselves, I think, is the biggest thing. But also being open to working with people when they come to you and say, I need you to meet my access need. Can you do this? And figuring out a way to do that, I think, is important.
People can get pretty caught up on the concept of conflicting access needs, but that sounds like a pretty simple solution. Another concern that people have is whether it's their place to advocate or to implement changes. What's the best approach?
Include voices of the disabled community in conversations around structural planning, around policy planning, around how care is provided.
one of the 10 principles of disability justice is leadership of the most impacted. And so every movement, every resource, every advocacy thing that we do should be led by people who are most impacted by the thing that we're advocating about, which to me means our talking points are created and chosen by people who are experiencing the thing. But I think it's important to recognize where we hold power in a space and when us doing the advocacy is actually going to help somebody versus hurt or take over someone's voice. So we shouldn't be speaking in place of people. And when people have the opportunity to do it for themselves, they should be able to. And sometimes it's a check-in. Like, for example, I used to work in an acute mental health inpatient unit, and we would see the patients pretty regularly. And then also on Monday mornings, we would have rounds. It would just be like only healthcare practitioners. And I was noticing a lot of misgendering from a lot of the healthcare practitioners. And I didn't want to out anybody. And this is especially one of those things where you don't want to out somebody. You don't want to give away information that isn't yours to give. But if you create a rapport with that person and you find out what they actually are comfortable with and what they want people to know, just sort of repeating that back to other people, I think is leadership of the most impacted while also doing the advocacy where you have the power in that space and you have the opportunity and someone else might not. And so in a situation where I was noticing that people weren't misgendering this person to their face, only in these, closed spaces with just healthcare practitioners. And so I started by just using correct pronouns. And then when I was noticing certain practitioners weren't really picking it up, I would just do the little correction of, hey, it's actually they. Hey, it's actually they, them. And eventually it sort of catches on most of the time. Sometimes it takes more of a conversation. But, little things like that. Yeah. And then similarly, especially when it comes to disability, like disabled people are often spoken for or spoken over. And I see this a lot. Especially in healthcare, a lot of disabled people feel the need to bring a support person to medical appointments so that they are listened to. But if someone uses a mobility aid, and especially if someone uses a wheelchair, people tend to talk to the support person more than they talk to the other person. And same with people who are deaf and bring an interpreter, people who are blind and bring like a sighted guide. There tends to be this feeling of I'm going to talk to the helper and not the actual person because that person doesn't understand. Don't talk to the support person. You are talking to the patient. Your patient is there to speak to you. The support person is there for that person and not for you. But if you are the support person, just reminding people, actually speak to them, or like going to that person. If someone asks you a question, being like, hey, this is your question, actually. What do you think?
Advocacy and improving access require a foundation of knowledge.
We don't know what we don't know, and also there are ways to know more. A lot of the times I run into people being like fearful of not knowing or fearful of doing wrong or doing harm because they don't have the answers. And while I was sort of, I said this before, there aren't necessarily like clear-cut black or white answers for a lot of these big questions, especially when it comes to gender diversity and disability. Like everything is a gray area literally all of the time. But there's things that we can learn. There's things we can piece together that are a little more black and white. Like assuming things about people, like myths and misconceptions, is not helping anybody. So let's avoid that kind of thing. Like those are pretty, I think, clear cut. And so starting there with the more clear cut answers of like, what can I do to engage with this information or like find learning opportunities that give me more information so that I am more aware, keeping up to date with what's going on around you.
The more you learn and the more you practice, the more natural these conversations will feel, and the better you'll be at being an advocate and an ally. Don't let the fear of making mistakes hold you back. You're going to make mistakes, and that's fine.
The difference between a professional violinist and a student is how they recover in doing a false note. I still misgender some people, and I will go and correct myself and be like, sorry about that so-and-so. Anyway, what were you saying about this? It's addressed between the two of us that I will work on doing better. And that trust has still been established because I said what I did wrong.
As a healthcare provider, remember that your patients may hold multiple identities, and these identities are not separate. They interact and they shape your patient's experience.
It's something you should probably have in mind for all your patients of what do they need? Have I checked in with how they're feeling or how they're identifying recently? If it's just part of your routine, then you won't get awkward and weird when you do have your trans patients, when you do have your disabled patients. Don't overthink it in a way, just make it part of your routine.
Going back to the whole idea of just reflecting on those biases that you may hold and understanding they are just that, they are biases.
Mm-hmm. Yeah, and just be open to things that are not within your experience that exist and are valid.
This is from Disability Visibility, the book of disabled short stories by Alice Wong, an incredible author, an incredible advocate, and just an incredible human being. The last paragraph of the entry, it's by Ricardo Thornton, and it was a statement given in front of the US Senate. I'm one of many people who could be here today. People sometimes say that I'm not like some of the other people with intellectual disabilities. The only thing that's special about me is that people believed in me and in my potential to learn in spite of my disability, and they took the time to help me. Please protect people from places where no one expects anything from them and where they're just kept alive. We can't go back. It's time to move forward.
Thank you so much for listening to this episode of Gender Queries. Thank you to our guests for sharing their stories and expertise. You can check out the show notes to find more information about our guests and how to find them on social media. There, you'll also find our transcript and our sources for today's episode. You can send us an email at genderqueriespod@gmail.com or find us on Instagram at genderqueriespod.